Yes, you may continue.
Right. Colleagues, we are moving on to a short overview of TB before we get into the nitty-gritties of latent TB infection treatment and the available regimens. So, TB, as we all know, colleagues, is a typical airborne infectious disease that is caused by a bacillus called Mycobacterium TB. Colleagues, we all understand that TB primarily affects the lungs, but it can also affect other organs, in which case it is referred to as extrapulmonary TB. When it's in the lungs, we refer to it as pulmonary TB. TB does not respect any organ, colleagues. It can affect the meninges, it can affect vertebrae, the liver, the spleen, the skin, the joints, the long bones. It really does not choose any side. So we know, and just to clarify it, that TB can affect the lung and stay in the lung only as pulmonary TB, but it can also spread to other organs as extrapulmonary TB. And colleagues, at this point, it is very important to note that in a number of our patients, TB occurs both in pulmonary sites and extrapulmonary sites as well. And it's also important to know that even in the context of HIV, where we know that TB tends to be more disseminated, or it tends to go to extrapulmonary sites more. Even in that context of HIV, pulmonary TB still remains the most predominant type of TB. Colleagues, we are also aware that TB can also enter the bloodstream and become disseminated to other organs, in which case it is referred to as miliary TB. So colleagues, let's be clear about it, because this has impact on the transmission of TB. The site of the TB is very important in understanding how TB is transmitted. So let's proceed to the next slide. This is where the site becomes very important. If we look at the transmission of TB, we know that TB is transmitted by those who are presenting with active pulmonary TB disease. If TB is only in extrapulmonary sites, we do not worry about the transmission. However, if there is any pulmonary involvement, then we worry about the transmission of TB. So let's get into the details of the risk of transmission, of infection, and of disease. So when someone with active TB of the lungs, pulmonary TB, coughs, sneezes, or speaks, they will emit small droplet nuclei that can remain suspended in the air for prolonged periods of time. It is said that these small droplet nuclei can become airborne and remain in the air for up to 24 hours in the absence of good ventilation, or if there is no ventilation at all. So if these droplet nuclei containing Mycobacterium TB remain in the air, it is known that about 70% of people who are exposed to these droplet nuclei will not become infected with TB. However, around 30% of those who are exposed to these infectious droplet nuclei will become infected with TB. Colleagues, obviously, as I've mentioned, there are risk factors that determine whether someone goes on to develop TB infection or not. And these risk factors are mainly environmental, as I've mentioned. Depending on where and how the person is exposed to TB, the risk of infection will differ. But overall, of those who are exposed to TB, about 30% go on to develop TB infection. If we look further at those who are infected with TB, not all of them will actually go on to develop TB disease. Only 5 to 10% of them will develop TB disease shortly after infection. And this, colleagues, is referred to as primary tuberculosis, the TB that develops shortly after someone acquires a acquires TB infection. The other 90 to 95% are able to contain the multiplication and the spread of the TB bacilli. And these bacilli will then go into a state of dormancy. They become latent. They can lie latent in a lesion for many, many years. And in some people, these latent bacilli actually do not progress to active TB disease. Colleagues, let's discuss further what is the risk of actually progressing to active TB disease. I pause here again, colleagues, to remind you that these individuals who develop latent TB infection, those who inhaled the bacilli but did not progress to primary TB disease, these individuals with latent TB infection are our target for TB, for latent TB infection treatment. So, colleagues, these individuals will contain the bacilli and they can actually contain it for years and years. Some people will not even develop active TB disease. So let's go into the details of who develops active TB disease following this state of latency of TB bacilli. It is said that about 10% of healthy adults who have latent TB infection might develop active TB disease in their lifetime. But colleagues, let's contrast that with those who are immune suppressed. Here we are talking about 10% might develop active TB disease later on at some point in their lifetime. However, if you contrast that with the HIV positive patients, you will notice that the risk of developing active TB disease following latent TB infection is much higher in the HIV positive patients. The risk is said to be around 30%. And colleagues, if we do not treat these individuals with ARVs and we do not treat the latent TB infection, we will not be able to reverse this development of active TB disease. But if we implement these two interventions, providing ARVs to all those who are HIV positive and providing latent TB infection treatment, we will actually make a dent in this number. Another high-risk group for development of active TB disease following latent TB infection are children. It is said that children under the age of 5 have a 20% risk of developing active TB disease after they have been infected with TB following latent TB infection. Note, colleagues, that the risk is actually double in those who are less than the age of 2 compared to those who are under the age of 5. And the reason for this, colleagues, we all understand, is because their immune system is immature, so they are not able to contain the multiplication of the TB bacilli that would be in their lungs or in other sites. There are also other high-risk groups, colleagues. In the previous presentation, Dr. Mawela also alluded to the clients or the patients with diabetes, those who are alcohol abusers, the malnourished. Colleagues, all those clients are high-risk groups for development of active TB disease after latent TB infection. These bacilli in these groups have a higher risk of reactivation and producing active TB disease. And that TB disease that develops after a period of latency is referred to, that type of TB disease is referred to as post-primary TB. And colleagues, post-primary TB can also occur in the lungs, in extrapulmonary sites, or in miliary, it can present as miliary TB. This will depend on where the bacilli were, I'm almost wanting to borrow from COVID-19, where they were quarantined and lay latent. If the bacilli were latent in the lungs, they will reactivate in the lungs. However, if they were latent in extrapulmonary sites, when they reactivate, the patient will present with extrapulmonary TB. Colleagues, in this next section, we are going to talk about the need for differentiation between latent TB infection and active TB disease. Colleagues, sometimes we get the terminology wrong and we just talk about TB, but for the purposes of this workshop, we are going to be very clear and particular about the language. Latent TB infection refers to those who have latent TB infection. We are talking about those who have latent TB bacilli lying dormant somewhere in their body. But those with active TB disease, we are talking about people who have active TB bacilli that are multiplying. And we are going to go further into the details of the differences. But colleagues, it's very important to differentiate between the two because the treatment of infection and the treatment of the disease are very different. Colleagues, we also need to make sure that we do not give or we do not provide latent TB infection treatment to individuals who actually have active TB disease. If we do so, then we really do risk the development of drug-resistant TB in those individuals. So colleagues, it's important that we differentiate between the two so we can treat appropriately. The table we are showing here makes a differentiation or shows us what are the differences between latent TB infection and active TB disease. On the left side, colleagues, you can see we talk about what are the features of latent TB infection. Let me start with the first one. When a person has latent TB infection, that means they have TB bacilli in their body, lying dormant or latent, and those bacilli are not actively multiplying. In short, colleagues, the bacilli are inactive. Contrast that with an individual with active TB disease. If someone has active TB disease, the TB bacilli that are in their body, whether it's in a pulmonary or extrapulmonary site, those bacilli are actively multiplying and they are active, in short. In an individual with latent TB infection, colleagues, the person will have no TB symptoms. The TB bacilli are inactive, and as a result, they do not produce any symptoms. Whereas in an individual with active TB disease, the person may have TB symptoms, and we are going to talk a bit more about TB symptoms later on. The person with latent TB infection, is very important to note, colleagues, that this person is not infectious, so they cannot transmit TB to others. The person with active TB disease, on the other hand, may be infectious if they have pulmonary TB, and they can transmit the TB bacilli to others when they cough, sneeze, or speak in other instances. The individuals with latent TB infection are treated, colleagues, with the regimens we are going to discuss today. They are treated with latent TB infection treatment. And the point of this treatment is to prevent those who are infected with latent TB infection from progressing to active TB disease. So the regimens we are going to focus on today, they are going to really cover what we need to give for the patient or the clients, let me rather call them that, because these are individuals who are not sick. They are well. We are trying to reduce or to prevent the development of active TB disease. On the other hand, an individual with active TB disease requires full TB treatment to cure the TB, prevent death, and also importantly, to limit or eliminate transmission of TB to others. So colleagues, those with TB treatment, we know the regimen we are using. Those are the individuals who should be getting the 6 months course of full TB treatment. In the first 2 months, we use 4-drug RHZE, and in the last 4 months, we use RH. That is full TB treatment that is required for an individual with active TB disease. Please note that an individual with latent TB infection is not regarded as a TB case. This is an individual who requires treatment to prevent development of disease, but we do not classify them in the TB program as a case of TB. A case of TB refers to an individual who has active TB disease, and we have very specific requirements for management of the case of TB. We all know that once we diagnose TB, using the correct ICD codes, we are going to classify the case, we are going to document the case in the TB register, and we have standardized follow-up protocols for these patients who are active TB cases. Colleagues, we mentioned in the slide before the one I've just presented, the high-risk groups for development of latent of TB disease after latent TB infection. This is a slide to just neaten up or tie up everything to say the group we are very focused on at this point are the HIV infected. We have seen that, and we know that they have a very high risk of developing active TB disease after they become infected with latent TB. This group is our primary focus that we are going to discuss today, but colleagues, we also need to be cognizant of the other groups that are at high risk of development of active TB disease. We have not included all of them in this slide, but just to highlight a few, children under the age of 2 are also a high risk group for development of active TB disease. We also talked about children under the age of 5, but we showed that the risk is even higher in those under the age of 2. Individuals who are on treatment by tumor necrosis factor alpha inhibitors are also a very well recognized high risk group for development of active TB disease. Those who are on chronic, who are on dialysis with chronic kidney disease, also a high risk group. Those who are preparing for organ or stem cell transplantation, those individuals are also a high risk group for development of active TB disease. Colleagues, this list is not exhaustive. Remember, there's also those who, the diabetics, who are also emerging as a high risk group for, and are a very well recognized high risk group for development of active TB disease. Do not forget the clients with silicosis as well. Those have also been shown to be high risk. The malnourished, also high risk, alcoholics. So colleagues, this is just a summary. The list is not exhaustive, but this is just to say our focus for this workshop are the HIV infected, but note that there are also high risk groups as well. Now, we've spoken in the slide differentiating between latent TB infection and TB disease about the presence of symptoms in those with active TB disease. Colleagues, this is just a summary. We deal with this every day. We are screening for active TB disease every day, but this is just a reminder to say which symptoms are we looking for when we are screening for TB. We know that in our program, we have a screening tool that we use that focuses on 4 main symptoms. And those are not the only symptoms of TB, but these are the ones that we always actively ask about. And we can ask about others in the consultation, but these 4 represent our minimum of care. If you say you have screened for TB symptoms, you should have asked about these 4 symptoms. Those symptoms are highlighted on the slide. It is cough, fever, night sweats, and unintentional weight loss. Colleagues, again, just to revise, remember that a cough, any duration of cough in HIV, in our HIV positive clients, is regarded as suspicious and should be investigated. However, in those who are HIV negative, we all know that if you look at our program, we generally consider a cough of more than 2 weeks as suspicious. But for any cough in an HIV positive individual should be taken into account. Fever is also another symptom that we look at. Night sweats, again, we are looking at drenching night sweats, colleagues. We do this all the time in our facilities, look for the symptoms. And the fourth symptom that we focus on is unintentional weight loss. Colleagues, if you look in the TB guidelines, there is we always say weight loss of more than 1.5 kg should be considered as a potential, flag for investigation. But we know, colleagues, that our patients and our clients don't always know what was their weight last month and what is their weight this month. So in general, for practical purposes, when a patient reports any weight loss, we take that into account and we act upon it. There are other symptoms that one could ask about, or that patients with a probable TB could present with. Not all these symptoms you don't have to have all of them to suspect TB. Some of these symptoms include coughing up blood, chest pain, loss of appetite, chills, fatigue. But colleagues, I repeat, a patient doesn't have to present with all of them before we start investigating for TB. If any of these four are present, that is reason enough to prompt us to investigate further for the presence of TB. And when we do investigate, colleagues, and here we have focused a lot on diagnosing pulmonary TB. So when we do investigate, colleagues, we know that there are certain tests that are available in our facilities for the confirmation of TB. Colleagues, culture, my apology. My apology, colleagues. There are particular tests that we have access to for bacteriological confirmation of TB. Culture is a test that has been there for a long time. We have used it for years and years to identify TB, and sputum microscopy as well. Colleagues, I just want to put a disclaimer up front that microscopy is no longer used as a bacteriological confirmation for bacteriological confirmation of TB. Microscopy is now used more for grading of TB disease and for monitoring of disease. We now have newer and more sensitive tests for confirmation of TB. Colleagues, I'm going to go through the tests that we are using for confirmation of TB in a bit more detail. Let's start off with culture. We have been using culture for many years, and the main advantage of culture, colleagues, is that it has a higher sensitivity than microscopy that we were using all along in picking up the real or positive cases of TB. Culture also allows us to do additional testing to determine if there are mycobacteria other than TB in the sample. Culture also allows us to do further drug susceptibility testing to determine if there is resistance to first and even second line drugs. Colleagues, culture has many advantages. As I've mentioned, a high sensitivity, high specificity, allows us to identify the mycobacteria other than TB, allows us to do additional testing to identify resistance. However, colleagues, the biggest advantage with culture is its long turnaround time. It can take between 1 and 6 weeks before someone gets bacteriological confirmation of TB. And if you want to determine if there is resistance to rifampicin and INH or there isn't, colleagues, the period would be longer. It will take you up to 10 weeks before you can get a result confirming resistance or absence of resistance. So colleagues, culture, a very good test, but it is limited by the long turnaround time. So what else have we got that could offer us a little bit more? Colleagues, a few years ago, I think it was in 2016, we got access to line probe assay, which is abbreviated as LPA in the slide. Colleagues, the line probe assay is a PCR-based test. This test is able to detect the DNA of Mycobacterium TB in a sample. And it also is able to detect changes or mutation in the DNA that confer resistance to rifampicin and INH. Colleagues, this means with one test, really, you are able to identify TB, and you are also able to test or to determine if that TB is likely to respond to rifampicin and isoniazid. LPA, colleagues, also has a good sensitivity, a sensitivity of 88% and a specificity of 94.6%. The turnaround time for LPA, colleagues, compared to culture is much shorter. In a week's time, actually, depending on sputum microscopy, in 72 hours to a week's time, you can have a result that tells you whether there's MTB. And almost forgot to mention, colleagues, also LPA is able to identify the mods very quickly. So within 72 hours to 7 days, you will get a result that confirms TB or identifies a mod. And if there is MTB, the result will also be able to confirm if there is rifampicin and or INH resistance. Wonderful test. But colleagues, there is a disadvantage with LPA. LPA, as you can see, the sensitivity compared to the other two I'm about to discuss is not as high. And let's talk about where that comes from. The LPA is not very efficient in diagnosing MTB in samples where there is a low bacillary load. So colleagues, for LPA to be positive, we need, or to be able to pick up MTB, we need to have a high number of bacilli in the sample. And that's why in the TB program, it was always recommended that it is best to do LPA in samples that are smear microscopy positive. Remember, for a sample to be smear microscopy positive, it means there is at least 5 to 10,000 bacilli per mil of sputum. That is a high bacillary load. So we are saying for LPA to pick up, there should be a high bacillary load. This is a bit of a downer, because when LPA was identified, we were already having significant challenge with diagnosing TB in the HIV positive individuals presenting with atypical TB where there are no cavities and the bacillary load is low. So colleagues, LPA is good. It has a lot of advantages, but the main disadvantage is its low sensitivity in picking up HIV positive clients presenting with low sputum bacillary TB loads. So colleagues, that is LPA. Now, enter the Gene Expert. When we got access to Gene Expert, colleagues, the problem of sensitivity, particularly in the HIV positive clients with low sputum bacillary loads, was addressed. The Gene Expert has a higher sensitivity. Actually, the Gene Expert Ultra, even better. In terms of specificity, also much higher specificity than the LPA. The turnaround time, colleagues, please note, we started off with Gene Expert. but now we have access to GeneXpert Ultra. The GeneXpert and the Ultra also work on the same principle as LPA. They are PCR-based tests. They identify the presence of MTB, specifically MTB DNA in a sample, and they will also pick up any mutations that confer resistance to rifampicin. So colleagues, please note the differences. The LPA picks up resistance to rifampicin and isoniazid, but the GeneXpert, both Ultra and the first GeneXpert we had access to, they only pick up resistance to rifampicin. So colleagues, the GeneXpert, much better test, picks up MTB, picks up a mutation that confer resistance to rifampicin, even shorter turnaround time, higher sensitivity, and also a higher specificity. The main disadvantage with the GeneXpert and the GeneXpert Ultra is that both tests do not identify resistance or the mutations that confer resistance to isoniazid. So colleagues, those are the tests that we have available for bacteriological confirmation of TB in the sputum: culture, LPA, and now GeneXpert Ultra. Microscopy, I've already mentioned, we are not using it as our main, as part of our armament for bacteriological confirmation, but we are using it for grading and monitoring of disease in both drug susceptible and drug resistant TB cases. The last test that we need to mention is the TB LAM. Colleagues, this test is provided or conducted in those who are HIV positive with low CD4 counts. This now is to overcome the lack of sensitivity of some of the tests when we have very low sputum bacillary loads. So where there is a low CD4 count of less than 200, colleagues, remember, you can use the TB LAM. We are going to pause here, colleagues. I will hand over to Dr. Mawela so that he can facilitate the discussions and the questions. Thank you so much, colleagues.
Thank you very much, Dr. Nki. Colleagues, before discussions, we still have one more topic, just looking at some of the evidence and discussions around the management of latent TB infection. So let's quickly go through those specific slides, and then we will then